webinar today is entitled Diabetes Documentation and Coding. Our speaker today will be Dr. Loren Lighthizer. Dr. Loren Lighthizer is board certified by the American Board of Emergency Medicine and completed his residency in emergency medicine at UCLA affiliate Kern Medical Center in Bakersfield, California. He has practiced emergency medicine within the Mount Carmel Health System since 1995. He is a member of the American College of Emergency Physicians, the American Academy of Emergency Medicine, and a member of the Columbus Medical Association. Dr. Lighthizer has served Health Partners as a physician liaison and medical director since March 2013. Welcome, Dr. Lighthizer.
Thank you, Ellen. It's a pleasure to be here and discuss this topic with you all today. Before we start discussing the specifics of diabetes, let's quickly review some risk adjustment essentials. Risk adjustment is a methodology by which CMS determines how to adequately allocate resources to Medicare Advantage plans for patient care. Both demographic and clinical factors determine resource allocation. Demographic examples include patient age, patient gender, institutional status, Medicaid status, and reason for being Medicare eligible. Clinical factors include chronic conditions that have been shown in CMS data to require more resources. As you know, there are 70,000 diagnosis codes included in ICD-10. Every year, each code is evaluated using CMS data to determine which codes utilize the most resources. Once the analysis is complete, the data is normalized so that the average Medicare patient has a risk score of 1.0. Around 9,500 diagnostic codes are determined to affect risk, and they each map to what is called a hierarchical condition category, or an HCC. An HCC is a group of chronic condition diagnoses that are clinically similar and have been determined to have a similar effect on resource utilization, or what is called their weight. These weights are what calculate the clinical portion of a patient's risk score, which will be discussed on the next slide. There are 86 HCCs that are included in the 2020 Risk Adjustment Model. For a diagnosis code to be captured on the claim, it must have supporting documentation within the record. An easy way to remember documentation requirements is the acronym MEAT, or M-E-A-T. This stands for Monitor, for M, Evaluate, for E, Assessment, for A, and T, Treat. Only one of these elements need to be present in the documentation for each diagnosis that is covered in the medical decision-making during a given patient visit. Examples could include metformin refilled for diabetes, which is a treatment, or diabetes is stable, an assessment. Both or either justify a diagnosis of uncomplicated diabetes. Next, we'll jump into information specific to diabetes. More than 34 million people in the United States have diabetes. It is one of the most prevalent chronic conditions in the population. Of the 34 million diabetics, between 5 to 10% people are type 1 diabetics, and the other 90 to 95% are type 2 diabetics. Diabetes is the seventh most leading cause of death in the United States, according to CMS. Diabetic complications are common among both type 1 and type 2 diabetics because diabetes affects every system of the body. It is important that patients are monitored for these complications each year and actively managed if they do have a confirmed complication. Risk factors for diabetes include age, or advanced age, weight, sedentary lifestyle, family history, and ethnic background. Tests to screen for diabetes include hemoglobin A1C blood test, a random blood glucose test, a fasting blood glucose, or oral glucose tolerance test. The American Diabetes Association recommends diabetes screening for anyone with a BMI over 25 or anyone over the age of 45. Within ICD-10 diagnosis coding, There are 5 categories that a diabetes diagnosis can be classified to. These include diabetes due to an underlying condition, drug or chemically induced diabetes, type 1 diabetes, type 2 diabetes, and other specified diabetes mellitus. Post-procedural, secondary, and genetic defects causing diabetes are all diagnoses that would fall under E13 or other specified diabetes mellitus. Listed are 4 important things to consider when documenting diabetes in a patient's medical record. It is best practice to state the type of diabetes in the medical record when known. If the type is unknown or is not documented within the record, the diabetes should be coded as type 2. A lab test showing one reading of an elevated blood glucose is not considered sufficient evidence of diabetes. The patient requires at least 2 or more elevated blood glucose readings to consider diabetes as a diagnosis. There are many complications that can unfortunately be associated with diabetes. In order to properly reflect the clinical picture of the patient, each complication that is caused by or associated with the diabetes needs to be documented and coded once annually. This includes any amputations that were caused due to diabetes, and later in the presentation we will discuss more regarding complications due to diabetes. This slide outlines some helpful tips when documenting diabetes for risk adjustment, evaluating diabetic services at each office visit, as well as adjusting therapy to improve hemoglobin A1C's levels is best practice. Make sure to remind diabetic patients to undergo yearly screening, such as nephropathy or diabetic eye exams. If these tests are not done, document in the medical record why the tests were not completed if known. Document patient education at each visit pertaining to medication adherence, diet, and exercise is important as well. Documenting that education was given for diabetes is best practice for risk adjustment. There are 3 quality measures that need confirmed for diabetic patients either within the measurement year or year prior. Diabetic eye exams should be performed by an eye care professional in the current measurement year or year prior with results documented. Diabetic hemoglobin A1C should be documented each year with a goal of less than 9. Diabetic nephropathy screening should be done once in the measurement year. There are a few exclusions to these 3 tests, which include patients with polycystic ovarian disease, gestational diabetes, steroid-induced diabetes, or hospice. One major change in the coding guidelines from ICD-9 to ICD-10 is the use of the word uncontrolled when describing diabetes. In ICD-9, there were codes for either diabetes as controlled or uncontrolled. With the changes made in the coding index in ICD-10, it is no longer appropriate to document uncontrolled diabetes, as this maps to 2 codes and therefore needs more specification on whether the patient is hyperglycemic or hypoglycemic. Alternative description that can be used in place of uncontrolled that indicate the patient has hyperglycemia includes poorly controlled or out of control, or just stating that the hyperglycemia is present with the diabetes. Z79.4 is a code that should be used when a diabetic patient is using insulin. When a type 2 diabetic is using insulin to manage their disease, it would also be appropriate to code Z79.4. If the patient is a type 1 diabetic, Z79.4 should not be used, since it is assumed they are using insulin. If a type 2 diabetic is given insulin only during a single encounter to temporarily lower or bring down blood sugar, Z79.4 should not be coded in this scenario. If a type 2 diabetic is using both insulin and an oral hypoglycemic medication, just code for the insulin should be reported. There are many combination codes for diabetic complications in ICD-10. Each time a patient's diabetes is being treated and they have a diabetic complication, a combination code should be documented in the note and submitted on the claim to capture the complication along with the diabetes. There are multiple complications that have a causal or assumed relationship with diabetes. Some of the most common causal complications include skin ulcers or diabetic skin ulcers, diabetic foot ulcers, cataracts, chronic kidney disease, neuropathy, and retinopathy. When these conditions in diabetes are both documented in the medical record, they should be coded together even if the provider does not state that they are related. The only time they should not be coded using the combination code is when the provider specifically states in the medical record that the diabetes and complications are unrelated. In this slide, you can see an example of a scenario where neuropathy and diabetes were documented well, but coded for separately. In this example, if this example was present in an audit, the auditor would instruct the provider to delete both G62.9 and E11.9 and use code E11.40, diabetes with neuropathy. Since the provider did not state in the note that the neuropathy is unrelated to the diabetes, it is assumed these conditions are related and should be coded using the combination code. Sometimes diabetes can be caused from an underlying condition. When this is the case, it is important to document this in the medical record along with the underlying condition that is causing the diabetes. In this slide, you can see examples of underlying conditions that cause diabetes, such as congenital rubella, Cushing's syndrome, or cystic fibrosis. When these are present and documented in the note, it is appropriate to code first for the underlying condition and then add a code from category E08 for the diabetes due to the underlying condition. This is similar for diabetes that is drug or chemically induced, such as chronic steroid-induced hyperglycemia-related diabetes. Document the cause of diabetes in the medical record and use a code first for the drug, chemical, or poisoning, and then a code from category E09 for the diabetes. Are there any questions over the information presented thus far?
It looks like there's no questions that have been chatted in. So in the next few slides, we'll go ahead and go over some examples that cover everything we discussed today. So the first example involves diabetes with the use of insulin. The patient is documented as a type 2 diabetic, and in the plan section of the note, the patient's insulin is refilled, which supports the diagnosis of diabetes. Since the patient has type 2 diabetes with no complications documented, it is appropriate to use code E11.9, type 2 diabetes without complications, along with Z79.4, long-term current use of insulin, since the patient is on insulin. Z79.4 is an HCC and therefore is risk adjustable. The next example shows that type 2 diabetes has been documented and also chronic kidney disease has been documented. Each diagnosis has great supporting documentation with status updates included for each. In this scenario, it would be most accurate to code E11.22, type 2 diabetes mellitus with diabetic chronic kidney disease. When the diabetic CKD code is used, coding guidelines also require a code to capture the stage of the chronic kidney disease. So in this case, N18.3 would also be captured on the claim. Our last example includes diabetes with a foot ulcer documented. There is great supporting documentation for these conditions within the record with margins healing and also left heel. In this scenario, E11.621 type 2 diabetes mellitus with foot ulcer should be captured on the claim, as well as the code for the location of the foot ulcer, which in this case is L97.421, non-pressure chronic ulcer of left heel and midfoot limited to breakdown of skin. We'll go together a few frequently asked questions to go over, kind of solidify the content that we discussed. So the first question is, if the patient has type 1 diabetes and is on insulin, should Z79.4 long-term current use of insulin be captured on the claim? The answer is no. If the patient is a type 1 diabetic and it is assumed they are on insulin since they can't make their own to survive. So Z79.4 long-term current use of insulin does not need to be captured on the claim. Question 2, if a patient has more than one complication related to diabetes, what should be coded? If a patient has more than one complication relating to diabetes, all should be documented in the record with supporting documentation, and each complication should be coded using a diabetic complication code. There is no limit to the amount of complication codes used for diabetes. There should be as many used as needed to capture all diabetic complications. The last question is, if diabetes is due to an underlying condition, should the underlying condition be coded along with the diabetes? And the answer is yes. If the diabetes is due to an underlying condition, the underlying condition should be documented in the medical record and coded along with the diabetes code.
To wrap up our presentation today, we will discuss some important takeaways from the content. There can be multiple complications due to diabetes. Remember, assess and code as many complications as needed to give a full picture of the patient's disease. Secondly, insulin should be added if it is clearly documented and supported for type 2 diabetes, but never for type 1. Type 2 diabetics are not always dependent on insulin, but type 1 diabetics are, so there is no need to capture the insulin code. Lastly, the more important information and detail that is documented about a condition, the easier it will be for an auditor to see the full clinical picture. This will also help most accurately capture the patient's burden of illness and help when other clinicians view the medical record when caring for the patient. We have some upcoming webinars in the next few months. April's webinar will cover congestive heart failure and chronic kidney disease documentation and coding, and June will cover depression document and coding. There will be no webinar in May. Please feel free to send any questions to any of the people listed below, and we will be happy to answer any questions. A participant questions log will be posted on our website following the presentation, which will outline questions asked during the live webinar as well as our frequently asked questions on slide 23. Please remember to return the attestation documents to Ellen Johnson by May 10th, 2020. Details will be in an email following this presentation, and thank you for taking the time to watch this webinar.